Welcome to Parallax by Ankur Kalra, a podcast produced by Radcliffe Cardiology to bring you a new angle of all things cardiology and the best from the US Cardiology Review. Published every second Monday, Ankur Kalra, MD, interventional cardiologist at the Cleveland Clinic in Ohio, USA, speaks with legendary cardiologists, reviews late-breaking trials, and interviews authors of our latest and best US Cardiology Review articles. We call them #audio articles. Parallax is the effect whereby the position or direction of an object appears to differ when viewed from different positions. So this podcast is your fix of reliable updates on all things cardiology by someone from a non-traditional background who is always looking at the industry from a new angle. Now, here's your host, Ankur Kalra, MD.
Hello, everyone. So this, I believe, will be aired in 2021. So a very happy new year to everyone who's tuned in and listening to Parallax. This is the beginning of season 3, and we're going to begin season 3 with a wrap-up of a year we want to put behind all of us. I'm sure 2020 has been a good hindsight for philosophical and various other reasons. But very happy to have with me to start season 3 a colleague who I respect tremendously and sort of is back by popular demand because, the episode that we had put together as a wrap-up of 2019 was actually one of the most downloaded episodes for Parallax at the beginning of 2020. So without much further ado, I have Dr. Nijjer. Sukh Nijjer is an interventional cardiologist at Imperial College in London. And, we're here to discuss everything that happened in the field of cardiovascular medicine in 2020. I think for our listeners, I want to break this to, COVID-19 and non-COVID-19 because, obviously the highlight of all of our lives, was COVID-19, whether or not we were in cardiovascular medicine or other subspecialties within medicine. So Sukh, welcome and thank you for doing this for us. And I'm glad you're well and safe.
Thank you so much, Ankur. Thank you for the kind invitation back. It's great to speak to you. We've clearly all been through quite a lot this year. So it's quite nice to just spend a bit of time reflecting on what's happening in cardiology, as well as what we've understood from COVID as well. So thank you for the invitation to come on your podcast.
Absolutely. It's always a pleasure. And, you did such an incredible job in summarizing, all the important studies for 2019 that, you were the chosen guest, by popular demand and also by choice to sort of do this for us in 2020. So let's get going. So
yeah, let's go for it.
Yeah, we've got a lot to cover. So I'm going to start by asking you about COVID-19. So that's novel coronavirus disease 2019, and it's I would say not only its manifestations from a cardiovascular standpoint, which are important, but also some of the decisions you and I had to make for our patients, because underlying cardiovascular illness was a significant comorbidity, which, predisposed patients to a severe form of COVID-19 illness. So, why don't we get started on, the story of the year, which is COVID?
Yeah, yes, absolutely. I mean, I think both you and I and all of our listeners will have all been working incredibly hard because of COVID-19. And I suspect majority of your listeners will be in those in the cardiology space and the cardiovascular space. As always, with all cardiologists, we like to make everything about ourselves. So even though the COVID-19 virus, the illness is COVID-19, and even though the virus is predominantly a respiratory issue and its pathology is predominantly lung, does cause quite a bit of cardiovascular issues. And we've understood that over time. At the beginning of the pandemic, we didn't really truly understand what was happening. And there were lots of misinformation. And we've come over the period of months to get a greater grip on all of this. And it really appears that the virus enters the cells. So it's spread by droplets. It may come in through your eyes or your mouth or your nose. And then it will enter through the mucosa and get into cells that express ACE enzymes, which are predominantly in the lungs. So lungs contain a lot of ACE, but also the endothelium of your blood vessels and your myocardium also contain ACE. And once a virus is taken up, it will then start replicating and generating new copies of itself, which is what its raison d'etre is. But it will then cause an impact on any of the organs that it's entered. So breathlessness, cough, and chest discomfort are very, very classical features. Patients will mount a fever, often a very high fever. And here in Europe and in the UK, we would say it's more than 38 degrees centigrade, which I don't know what that is in Fahrenheit. I presume that's over 100 in Fahrenheit. And but they also have a lot of anosmia, so they have loss of smell, and that's because the nerve attacks the olfactory nerve. There can be GI upset because it is and patients can have diarrhea, and they can have headache. And we've even seen patients presenting with stroke, probably because of a combination of embolic phenomena and involving the cerebral arteries. So there's multiple different effects that this seems to have. And in relation to the heart, there's three main components, right? So there's the fact that the virus will have a greater morbidity and mortality in those patients that have got cardiovascular disease. Second component is that we know that patients with COVID-19 have some form of cardiac damage that's detectable. Now, we can argue about the significance of that and how much attention we should pay to it. And then the third component is that certainly in the United Kingdom and in mainland Europe, there's been a huge reduction in normal healthcare services because of the COVID pandemic. And I know listening to the various different podcasts that come out of the US, I was interested to hear that even at the height of the COVID pandemic, many people were continuing to do elective cases and things. Certainly at the very first wave that we had in the UK, all elective work had to be stopped and discontinued. So that will have a huge impact on our patients. Now, if we think of our typical cardiac patients, most of them will have some form of perhaps hypertension. They may well have atherosclerosis. And what we see in those patients, if we look at the patients in case series that have been published, first coming out of China and then out of Italy, Spain, and then New York, is that a very consistent story. We see that patients with elevated blood pressure are much higher risk of developing a more serious illness that requires hospitalization. So I think it's fair to recognize that COVID-19 is a serious virus, but actually the vast majority of the patients actually have very minimal symptoms. So many patients can be managed at home, and many patients will have a self-limiting illness that maybe lasts for 10 days to 12 days, and then they generally get better. And the cohort that we see as hospital-based physicians are those who are much more serious. So those that have started manifesting the second stage host-inflammatory response component, where the body is generating a huge amount of so-called cytokine storm with elevations of interleukin 6 and other interleukins. And so we see a kind of sick cohort. And those with cardiovascular disease appear to have a higher chance of having that kind of sick stage. Then we also see that many of our patients develop a troponin elevation. Now, we've got to be careful because remember, there are multiple different types of troponin elevation, and it's not all classical acute coronary syndrome. This isn't necessarily plaque rupture with occlusion of the vessel causing either a STEMI or NSTEMI, but it may often be a troponin elevation due to myocardial inflammation, and we've seen myocarditis, and also a oxygen perfusion mismatch. So the patients are hypoxic, they can't breathe, their lungs are full of this inflammatory material, and we've seen that many of the patients have very low saturations. Combine that with a background of coronary disease and plaque, and a level of shock, reduction in blood pressure, and then you will get a situation where the perfusion to the territories is not sufficient. And so it's unsurprising that you get a troponin elevation in these patients. Now, what's interesting is all the data out of China and the studies in Italy and Spain all corroborate that the size of the troponin elevation is related to the patient's level of risk of mortality, certainly in the near term. Okay, harder to say long term, but certainly in the near term. And we've got data that's come out of China that shows that those that have got troponin elevation are much less likely to survive at 30 days than those who've had no troponin elevation. And of course, just like all other myocardial injury, the size of the troponin elevation does strongly relate to the risk of mortality, and it predicts needing ventilation and inotropic support. All of these things are intuitive. The more damage to the heart, the greater the chance the patient's going to be unwell and get sick. And this is probably all driven through this this point of attack that SARS has. It's a SARS-CoV-2 virus. It's got a spike protein that seems to bind the ACE2 enzyme, which is expressed on the surface of these cells. These cells are in the myocardium, they're in the endothelium, and that seems to cause all of the issues. But what's interesting is very few of the studies have actually demonstrated the virus being in myocardial cells. It seems to be causing a lot of the damage through inflammation, and there is certainly evidence of macrophages and other tissues within heart specimens. But there also seems to be a lot of clotting. And I think many of us who've been on the floor dealing with patients who've got this, is that clotting is a major feature. And at the very beginning, there was data coming out of China suggesting there was a clotting abnormality component related to this. And I remember a lot of my colleagues here in the UK were very disinterested in this, and they said, oh, well, we don't think this is true. We think this is a little bit of nonsense. And this has now come out fairly clearly that there is some form of clotting abnormality. Now, whether these patients all deserve to be on some form of anticoagulant is less clear. And I would say, we really need the data for that. I spoke recently to Roxana Moran at one of our Imperial congresses, and she was fairly clear that she felt that, this needed to be studied in a randomized control study. And in fact, at Imperial, one of our colleagues, Professor Kanagaratnam, is running a study in which we're randomizing patients to aspirin and clopidogrel and low-dose rivaroxaban, 2.5 milligrams BD, if they've got confirmed COVID and require hospitalization. We don't know what that's going to show, but it may offset some of this elevated risk that seems to come in the COVID. And I don't know about you, but I've seen the whole spectrum of cardiovascular complications with COVID. We've seen traditional myocardial infarction. We've seen NSTEMI. We had a huge glut of NSTEMIs. I've seen STEMIs with very, very bad thrombotic occlusions with very high thrombus burden, which is hard to explain if it wasn't for the COVID. We've seen classical myocarditis with huge troponin rises, very high CRPs, very unwell patients. And we've seen patients acutely decompensate with perhaps underlying DCM that hadn't been picked up. And then they suddenly develop acute heart failure in a young patient, and these patients have had to go off and have ECMO. I've also seen patients develop spontaneous ventricular thrombi, and that's led to stroke. We've had at least one patient that's had a very young patient that had a stroke. And as with everybody else, we've seen PEs galore. I mean, pulmonary emboli seems to be a significant feature, particularly of those patients with hospitalized COVID-19, very unwell. D-dimer seems to be very high. And if you perform the lung imaging, you will see clot in a lot of these patients. And that may explain some of the troponin elevation, may explain some of the chest pain that some of these patients have. So certainly this is an important factor. And whether this is all driving a huge amount of STEMIs or not is really kind of now been answered by the first two waves that we've had in the UK. We've not seen this big fear come to its conclusion that we really thought was going to happen, that we were going to have wave after wave of STEMIs. What we've seen is patients have actually sat at home and not come in despite having chest pain. And we've seen patients have complications of heart attacks that haven't been treated promptly. But we haven't seen this huge volume of STEMIs driven by the virus itself. And so I'm sure you saw a lot of the stories coming out of Italy with these sharp fin ST elevations in young patients, which was actually due to a form of localized myopericarditis rather than classical STEMI. And we didn't get drowned in that. We thought we would, but that didn't happen. Now, long term, we don't know what's going to happen to these patients that have had COVID. Certainly, I've dealt with patients who've been completely fine, but I've got a lot of patients now on my books who seem to have this long COVID, which is not incredibly well codified, but we're basically referring to it as anyone that's got ongoing symptoms after perhaps 3 months after their original COVID infection. And so if you've got that kind of phenomena, I should say 3 weeks rather than 3 months, then I think then these patients tend to be very breathless, they tend to be fatigued, there's a lot of chest pain, joint pains. I think some of these patients have a lot of anxiety. They've been through a significant illness, which in some cases has been the first time they've ever been that unwell. And I think it's difficult to know what tests to do for these patients without overdoing it. And I know there's been this controversial paper from Valentina Puntman's group from Germany that has shown that a lot of these patients have late gadolinium on cardiac MR. We have great access to MRI in our institution. We do a lot of MRI, and we have seen this. But again, we don't know quite how to interpret it because, of course, influenza and other viruses also cause gadolinium changes within the myocardium. And so I have to say I side a little on the conservatives group, those who are basically saying don't do the imaging unless absolutely necessary. So I think if you've got a patient that's suffering with perhaps a high burden of ventricular ectopy or profound ongoing breathlessness and you're very worried, then I think that's worth doing. But for asymptomatic patients, I wouldn't advocate putting all these patients into an MRI scanner.
Yeah, that's you actually ended in a really good note, because that was going to be my question to you, because I've seen a lot of these follow-ups in my clinical practice, in the clinics. A lot of these patients who were diagnosed with COVID-19 were hospitalized maybe for a day or two, or sent home from the emergency department in isolation for 14 days. Had mild upper respiratory symptoms, so they self-isolated themselves and they quarantined, and then they were told to follow up with cardiology because they were either tachycardic, or they were having a few extra beats, or maybe in the emergency department someone drew a troponin and the troponin was positive, but they were not administered a stress test because they were thought that they were low risk, and COVID, the troponinemia was attributable to COVID-19 illness. How do you do we have to risk stratify these patients outside of what we usually do, if we get such a patient?
Yeah, I think we don't know at the moment. I think that I suspect for the vast majority of these patients that they actually had a troponin elevation like a type 2 myocardial infarction, so related to a myocardial stress and injury as opposed to plaque rupture. And if you've got a patient in front of you who's had this situation and they've got hypertension, hypercholesterolemia, they've been a smoker and they've got a strong family history, then you would do anything that any cardiologist would do, which is risk stratification. But if you've got a younger patient who's physically very fit, never had any further problems, I don't think we need to start performing stress testing in all of these patients unless there was key symptoms that raise concern. So in a well patient, I think we should be cautious because we create a lot of anxiety. And I think a lot of the patients that come and seek our advice regarding this is partly because social media and because of, certainly here in Europe, we have something called WhatsApp, which I'm sure you're familiar with. WhatsApp is a messaging platform, but you'll be amazed on how stories and complete fabrications go around on that. I don't use Facebook, so I imagine Facebook is very similar, given that they're owned by they're basically the same company, aren't they? But the misinformation that spreads and the anxiety that gets driven by that is absolutely huge, even amongst medical professionals. And so I suspect we kind of make people worry unnecessarily. Now, there are some of my colleagues who are very worried that these patients are going to have long-term heart failure. And I think if you've got a patient that has symptoms and they've got gadolinium and they've got a reduction in function, then you should treat these patients appropriately. These patients should get ACE inhibitors or angiotensin II receptor blockade and be treated with a best-in-class medication. But I think we should also recognize that we don't really know what's going to happen. And I suspect the majority of these patients have a syndrome of symptoms that are very similar to other post-viral syndromes. So if patients with influenza or even the common cold can get a post-viral fatigue syndrome. So I suspect that there is an overlap of that with our patients. One thing I'd be interested if you're seeing this phenomenon is we're seeing a lot of pericardial effusions. And this does worry me a little bit because it's hard to pick up unless you've done an echo. And we've had a couple of patients that have actually needed drains because there was an impact and they had echocardiographic evidence of some form of compression. So this is something that does concern me, that there could be a lot of patients out there who've had pericardial inflammation and then developed effusion that may well be important. And of course, particularly if they're young and they're having simple fainting symptoms or something along those lines, then patients, other physicians may ignore those because they think, okay, well, young person who's having a faint, perhaps less important. Is that something you've seen at all?
It's interesting that you mentioned it because, with us, particularly where, I work, in the cath lab, for us, effusions come in, they come in waves. So, we would have, like there would be a week with 6 to 7 taps, and then, a few weeks would go by, and then we would have another week with 6 to 7 taps. And I'm wondering, but it's interesting that you mentioned that because, particularly in 2020, we've had more of those kinds of waves than we've had, for example, in 2019. Although, this is all anecdote and really have to go back and see, whether there was, whether there was something of this sort, which was pandemic driven, something actually a really interesting project for us to.
Yeah, absolutely. I should hasten to add, you're absolutely right. Most of this is based on anecdote, right? So, I could put together the collection of patients that I've seen and publish it and then say I've got an evidence base. But really, again, these kind of patient series things are still anecdotes. So hard to draw much conclusion from it other than to say, our particular set of hospitals that work in our particular way of working has seen this phenomenon. And I'm not sure how much to conclude from it for in other services, because healthcare services around the world are designed very differently. And so it is difficult to know what is translatable in that regard.
Yeah, but I think it's an observation, right? It's a clinical observation, and similar to what we reported, like an increase in the incidence of stress cardiomyopathy was something which we saw in our cath labs, and we thought it was a fair question to study in a systematic fashion. I think maybe we could undertake using the Cleveland Clinic Health System data from the cath labs that we have, look at what percentage of pericardial effusions needed to be drained during the pandemic compared with the pre-pandemic months, and see if there is any association. So probably hit you up on that, Sukh, if
absolutely. So here we go. We've got now we'll have pressure to actually do the project now because we put it on the podcast, right?
Yeah, absolutely. We'll be held accountable. Yeah. So Sukh, just to end the segment for COVID-19, what are sort of the take-home messages for the cardiologist who's out there in the trenches taking care of patients? And what are the important take-home messages for cardiologists out of the COVID-19 pandemic, according to you as a practicing cardiologist yourself?
Okay, so I think tips for cardiologists who are on the floor, who are actually dealing with patients with COVID-19, I think there are a couple of things that I would say. One is to make sure that you are protected. And I think there's real importance to make sure you're wearing the proper PPE, that you're using it appropriately, and not reusing equipment. Make it available. Get it. We brought in a lot for our staff as well as for ourselves. And get the vaccine if it's available to you. It's really great to see everyone on social media posting their vaccine photos. It's valuable to take it because you don't want to be a vector for the virus itself. Our patients are vulnerable, the cardiac patients are vulnerable. And if you're going between patient to patient, it's worth making sure that you are not the vector of taking the virus to our vulnerable patients. And then I think it's worth recognizing that our patients are more vulnerable than perhaps others. And so go through your lists of patients, go through your clinics, identify those that are most at risk, and make sure that those patients are appropriately treated, make sure everything's optimized, and then also reduce the amount of testing that you do in these patients. If it's not necessary for them to come in for a series of tests, then defer them. And it's not that they can never have these tests. They can be performed later after the pandemic. And I think there's great evidence from many of our studies, particularly in stable patients, like the ischemia study, that shows that in the near term, we can manage many of these patients conservatively for a period of time. And so that's what we've done here in our hospital network. A lot of elective work was deferred and cancelled, and we've kept up to date with many of these patients. There's been very few patients having any major events whilst they're waiting. And so I think that it is safe to be able to wait. In those patients who have to have procedures, then obviously make sure you follow the appropriate guidance. And I think, we've got used to doing all of our procedures wearing layers and layers of PPE. And hopefully we can, as we get vaccinated, we'll be able to lessen that. But certainly in the near term, we're doing everything with appropriate protection.
All right, excellent tips for all the practicing cardiologists out there, who are still going to be taking care of COVID-19 afflicted patients, as we hopefully start to see the beginning of the end of this pandemic. I would hope. But moving on, thank you, Sukh. That was terrific. Sort of summary for us to keep in our minds as we practice cardiology. Now, moving to non-COVID-19, studies from 2020. I would like to start off with STRENGHT, because I think that was one of the major trials, out of the Cleveland Clinic, presented at American Heart Association annual scientific sessions. It drew a lot of attention because it was compared with findings from REDUCE-IT. REDUCE-IT, as we know, was the purified derivative of icosapentaenoic acid, so icosapentethyl, which, at a dose of 2 grams BID, so that roughly translates into 2 capsules you take twice a day. That was what I was doing in my clinical practice. Reduced events in patients who were, statin-treated patients, so patients with normal LDL. But what STRENGTH showed was different, right? STRENGTH, and you'll probably discuss about this and get into the nuances. But the point of controversy was actually not only the study arm, but also the placebo arm. But I'm going to let you discuss both those trials.
Yeah, gosh, I mean, it did create a lot of controversy, and it has led to a lot of discussion. So let's talk about it. So I'm going to put my hand up straight away and say that Vascaper is not available in the United Kingdom, and so I have no clinical experience of using this drug. Although we've actively been telling our patients that we're hopeful that this drug will become available, and people are very interested in it. And the reason they're interested comes from the fact that it sounds natural. It sounds like something that patients are very happy to take. I'm always amazed. In fact, just before recording this podcast, I just saw a patient whose list of supplements that she was taking was, I think, 14 different supplements, and she was completely abhorrent at the idea of having to take a normal, in inverted commas, medication. She was very happy to take all these other things because she had read them in various magazines and things that they were helpful. And so I think the desire for a drug like Vascaper to be effective sounds very attractive. Here is a medicine that is essentially a natural, purified oil that if only we could get enough of it in our diet, then we would all live forever. And I think that's what makes it so attractive. And so when REDUCE-IT came out, there was huge excitement driven by the quite massive risk reduction by adding in this simple purified medication. But then there is a bit of controversy about that in itself, right? So the randomized control study used a mineral oil as the control, and the feeling is that the mineral oil is a safe alternative and therefore counts as a reasonable control to use. But there is some evidence to suggest that the mineral oils themselves perhaps are harmful and may well be causing an abnormality in patients' LDL levels. And if you look at that study in detail, you'll see that LDL levels were actually rising in the group of patients who are on the mineral oil placebo. And it might be that, it's difficult to know why this may be happening. It might be because patients think they're getting the active drug. And so they think, okay, I'm on my statin, I'm on my active drug, therefore I'm going to alter my dietary habits now, and I can eat more burgers and chips. And that's what's causing their LDL. But it also may be driven by the fact that the mineral oil seems to have some interaction with your statin that you're taking, and may also be pushing up your LDL levels. And therefore, it may not have been a truly inert placebo. But what's interesting is that the FDA looked at this, and they did do a deep dive on this, and they felt that this was not a valid concern. And although I know that some key guys at Cleveland have really pushed on this, they haven't. This hasn't been the overall feeling that this is a fluke finding in the REDUCE-IT study, because there is another study I think it's called I don't know how to pronounce this actually. I think it's the Gellis, or I don't know. Is it pronounced Gellis as well? It's written in a kind of unusual way, and I think they were going for something quite funny. I love cardiology study acronyms, so they went for Gellis, and they show a similar reduction in lipid levels when you take basically this purified fish oil. But what's interesting is in the STRENGHT study, which is an interesting study because it's pushed by, I believe, AstraZeneca. They're producing this as a mass-produced oil, less refined than Vascaper, and it's combined with some other oils. So you've got the EPA, but you've also got DHA in there as well. And the hope was that it would be an easier to produce medication that would then have a similar effect. And what they found in this very large study, about 13,000 patients, with each arm around 6,500 patients, and good representation of cardiovascular risk. They've got more women than many studies do. Around a third were women. They had a 70% patients with diabetes. And they took patients with proven atherosclerosis as well as those with risk factors. But they ended up having to stop the study early because for futility, because they weren't seeing any difference at all. And it's interesting that in STRENGTH, they're also not seeing a reduction in LDL levels as they saw in the REDUCE IT study. So it implies that something is going wrong here. And there's lots of people have thought about this. And one of the reasons they thought is perhaps the DHA, which is part of the mix that they put in with this particular drug, is minimizing the effectiveness of the EPA. So we don't know for sure, but it's a theory. And it would be interesting to see if this bears out. We know that DHAs do have some negative effects. And therefore, it could be that the negative effect of the DHA is counteracting the EPA. And what's interesting is we're not seeing the big reduction in LDL levels. Now, the patients who went into this study all had high triglycerides, they all had low HDL levels, and they all had high LDL levels. So these were high-risk patients. And what I like about the STRENGTH study is not just the fact that, okay, it's a negative study, so it creates some controversy and people kind of say, so what? Do we need to stop using these drugs? But what I like about it is that it truly shows what the event rate of patients with cardiovascular disease is if monitored over a period of time. Now, bear in mind, these are motivated patients because they've entered themselves into a trial. If you look at 12, 24, and 48 month data, what we're seeing is that you essentially got an event rate of around 20%. And so if you're seeing a patient who's on good medical therapy, optimal medical therapy, then the event rate that they're going to be at risk of in stable patients is around 5% at 12 months, 7.5% at 24 months, and around 10% at 36 months. And so that's incredibly useful information to be able to tell our patients when they come to us with elevated lipids and medication that could still need a bit of improvement, is that even with the best things on board, they've still got an elevated risk. So they need to be careful. They need to watch their diet. They need to ensure they're taking the appropriate exercise. And so I think even though the study is negative, there is some positives to be drawn out of it. And I like looking at studies like that because it does inform about the overall risk for our patients. Now, I'd be interested. Now, you guys use a lot of Vascaper. So what's your experience been with it? And are you finding that patients enjoy taking it, that they've get on well with this fish oil?
Yeah, so I've actually been an early adopter, of purified fish oil derivative, thanks to REDUCE IT, and I've seen very very promising results in my clinical practice. It's amazing, what was a revelation to me, Sukh, and maybe it should not have been a revelation to begin with, but I started. Particularly after the results of the REDUCE IT were announced, I really started keying into lipid panels and specifically looking for triglyceride levels. And to my surprise, over 50% of my practice, was REDUCE IT study population. So, even though, there was, incredible LDL reduction with, high intensity statin therapy, which is what we prescribe to our patients after an acute coronary event, when I was seeing these patients and follow up in clinic, 6 months down the road with more than 50% LDL reduction, And, with LDL values less than 70, their triglycerides were still elevated, like into the 170s, 180s to 100 ranges. And these were not diabetic patients. These were just, perfect reduced patients, quite frankly. And, when I started, when I brought up Vasipa and the dose, and I did say, look, it's a capsule, it's a gram capsule, so it's the recommended dose is 2 grams BID. So you got to take 2 capsules in the morning and then 2 capsules in the evening. They seemed fine with it, just like you said, just because it was some form of a purified nutrient.
Yes.
Yes.
There's something very attractive about that. People like the idea that it's just they think of it as a health food supplement. They don't think of it as a medicine.
Exactly.
It's an odd phenomenon. But it's quite. I understand it's quite a big. It's quite a big capsule as well, right? So
it is. Yeah, it's a sizable capsule, and the compliance was not a challenge at all. I mean, it's challenging.
It's funny, right? Because the atorvastatin 80 milligrams is quite a large pill. And I get that complaint every single patient I prescribe it to. They come back and say, "Oh, this pill is massive. I can't swallow this pill." And yet they'll be happily swallowing these massive fish oil capsules with no difficulty at all. So there is a huge psychological barrier about these. But I think you're absolutely right. This just shows how blinded we become as cardiologists and other physicians. We focus on what we know and we focus on what we can treat. And the focus has been on LDL-C. And we measure LDL, we target, we know what to do with it. Triglycerides, we just don't quite know what to do with. And the drugs haven't been so good. The fibrates aren't great. And they were downgraded in their recommendations as well. And patients don't always tolerate them. And so we didn't really have a great medication to be able to give patients with this. Now, I think if we do use medications like Vazkepa, then I'm sure we will get these reduction. And I would hope that it reduces the event rates. What I see a lot in my practice is a lot of type 2 diabetes. And in West London, where Imperial is based, we just have an absolute sea of patients with type 2 diabetes. And so we're already pushing a lot of these patients onto medications like the Sglt2 inhibitors, and I can imagine once these EPA type drugs come available in the UK, we'll also be pushing these particular medications. Until then, I've actually been saying to them, just go out and buy a fish oil. But then it turns out that probably isn't the right advice, because as this study, STRENGHT, has shown that not all fish oils are alike. And this particular one, although it's pharmaceutical grade, the combination of DHA seems to be harmful, or it seems to have a negative impact. It certainly causes your LDL levels to rise. So that is not a great thing.
Yeah, I mean, my conclusion was that not all fish oils are equal, right? And I think there's something to be said about the endpoints of reduce it. Even though the naysayers would say that mineral oil, spuriously raised LDL and that it should not be treated as a true placebo. But as you pointed out rightly, the GELIS is another study that actually showed what reduce it showed. So there's something about purified fish oil that is driving the endpoints, in my opinion. And clinically, I did see that in patients, there was a significant drop in triglyceride levels as well. So it's sort of become, before I would add ezetimibe, I would say, statin, high intensity. Okay, you've got a good LDL reduction. If your triglycerides are high, I'm going to start you on Vasipa, and sort of you should be on that BID.
Well, we look forward to getting it because I think certainly the UK mentality would be that the patients would love taking it. I just hope in terms of costs and things, I think this is always a limiting factor. We would have to get through NICE approval in the United Kingdom, and so that always delays things.
Yeah, no, look forward to your experience with it. My experience certainly has been very positive. With patients. So moving along, some big action, in electrophysiology with our EP colleagues, and particularly with regard to how you manage paroxysmal atrial fibrillation. Do you want to talk about those trials, Sukh?
Yeah, absolutely. So, I mean, I am an interventional cardiologist, but a lot of my outpatient clinical work is general cardiology. So I see a lot of patients with atrial fibrillation. And I think many of us will recognize that there are those patients who are very symptomatic from AF and others that have no symptoms at all. And in the United Kingdom, AF ablation is generally a second-line therapy after medication. And the UK's NICE essentially says that you can have an AF ablation, but only after other medical therapy has failed. And AF ablation is very commonly produced procedure, but the difficulty is that there are lots of different competing technologies. There are lots of different ways that AF ablation can be performed. I'll hold my hands up and say I don't perform AF ablation, but I'm not sure I can tolerate doing a single procedure for 4 hours like my EP colleagues do. But there is different procedures, and they do have different levels of success. And I think it's fair to say that many patients, particularly with chronic or permanent AF, may need more than one procedure in order to return them to sinus rhythm on a long-term basis. And also, there was towards the kind of beginning part of my career, and this came out when I think I was what you guys would call an intern, was the AFFIRM study, which basically showed that actually when you're looking at rate versus rhythm control, there didn't seem to be much difference. And this whole concept of aggressively pursuing rhythm control meant it didn't really alter the patient's trajectory. And so this perhaps downgraded the use of ablation and other adjunctive therapies to return people to sinus rhythm. And yet we've got patients who are very symptomatic. And so what's really nice is that the STOP AF and the early AF studies are two very similar studies, and I believe are using similar catheters. And what they have basically shown is that actually early ablation appears to be better for patients in terms of maintaining their rhythm and keeping them in sinus rhythm and therefore reducing symptoms. And that cryo balloons and cryoablation is both safe and effective and will basically simplify the procedure. And those who perform ablation will know that cryo ablation therapies are much quicker. In fact, there's a colleague of mine who works on the other side of London, Richard Schilling, who's really pioneered cryo here in the United Kingdom. And he actually moved to performing cryo in small outside hospitals. So not tertiary centres, not big academic centres, but in small district general hospitals, as we call them here in the UK. And he's also doing it in small outpatient facilities, so day case facilities. So that's quite a significant innovation. And he has really pushed this approach to AF ablation. And many people would have said, okay, well, that's a little bit aggressive, it's a little bit unnecessary. But these studies now, STOP AF and early AF, are kind of really supporting that view that in selected patients, a little bit younger, perhaps, we're not talking about 80-year-olds, we're talking about much younger patients who are symptomatic from their atrial fibrillation, then don't sit on them with medications or give them toxic medications for rhythm control, rather refer them early for AF ablation and to be able to achieve better rhythm control in a relatively more straightforward procedure, which is quicker and has less complications. So I think this is a positive development in the EP field. And it's great to see EP have actually, after a long time of basically sitting it out, I think they learned from interventional cardiologists. Interventional cardiologists had kept doing studies that basically showed that coronary intervention doesn't work in stable disease, and were putting themselves out of a job. And so the electrophysiologists kind of sat on the edges, didn't perform the studies until they'd really refined their techniques, got better technologies, and now have produced a series of studies, including Castle AF from a couple of years ago, that show that if you select your AF ablations, then you can actually do real benefit for your patients. So I think this is really positive.
So in terms of clinical practice and, talking to patients, has it changed for you, Sukh?
Yeah, well, absolutely. So we've had, we work in our practice, we're very close linked with our EP service. We have a lot of multidisciplinary team meetings. We discuss our cases. And as we become more and more subspecialized, it's always sensible to discuss patients in this kind of setting. And what we found is that we do now refer more early. And patients who perhaps we wouldn't have referred before because we thought that, okay, well, yes, they're symptomatic, but we're going to just manage them on beta blockade and digoxin and maybe some amiodarone, then actually we've had successful results by referring them for ablation. Now, again, this is anecdotal evidence, but the studies certainly seem to support it. So, and we've been pushing in this direction, and patients seem to prefer it. The difficulty that we have, of course, is that AF ablation procedures can be quite long, and so the waiting times, certainly here in the UK, can be longer than we would like, and there's a push to kind of solve that.
Yeah. So moving along, Sukh, talk about RHAPSODY. Interesting name, interesting acronym. I am always in awe of how cardiologists come up with these amazing acronyms.
Oh, these acronyms are wonderful. I love them. I love the names that they come up with. So RHAPSODY is an interesting study, and I think it's essentially for a relatively small niche of patients, but patients that are particularly troublesome and are difficult to manage. So it's a study that looks at anti-interleukin medications. They're inhibitors that block various interleukins. And it's there to treat patients who've got recurrent pericarditis. So we've all seen and had patients that have had recurrent pericarditis with multiple admissions, keep needing to have strong non-steroidal medication, and sometimes move on to using steroids. And it's real troublesome to treat these patients. And if you don't treat them, then there is a risk that the pericardium become thickened and they can develop a constriction type picture. And we've got a few patients that have ended up needing to have pericardectomies. And as you know, that's an incredibly complex and difficult procedure, and can have associated high complication rate. So what these guys in the RHAPSODY did was to look at this new immunological drug, a biologic, as they will refer to it, rilonacept, if I can pronounce that correctly. And what this drug did was had a massive reduction in the recurrence rates of pericarditis. There are a couple of interesting things about this study. So it's a relatively small study. I think it was about 80 patients initially, and then they completed only 61 patients. So you've got to take a huge amount of caution in interpreting these results, because although their P numbers are absolutely huge, the number of zeros is really long, but the total number of patients they recruited are small. And these patients all had to have a run-in period, and they had a run-in period to look to see if they could tolerate these medications. And any study that has a long run-in period always concerns me, because in real life doesn't include run-in periods. You've either got to give the patient the drug or not. And giving them drug for a period is to see whether they're going to have a side effect and therefore can go into a study, means that you've already starting to make your study a little bit more niche. And then their definitions of recurrence of pericarditis were relatively soft, I would say. And what they found is, remember this is an unblinded study, is that the patients who were on the drug had trivial recurrence. So in the time zone that they looked, they had a recurrence of like 6% or 7%, so a very low percentage. And in those that were not on the drug had a very high rate of recurrence, so 74%. And so naturally that drives a lot of excitement. But I have to say that the number of patients that will get this drug will almost certainly be very small. And as with all of these immunological drugs or biological drugs which suppress the immune system, they come with some costs, and that cost appears to be respiratory infections. And the likelihood of getting a lung infection or a pneumonia goes up quite a bit on these medications. So blocking your interleukin system will undoubtedly mean that your immune system is somewhat suppressed, just like there are patients with rheumatoid arthritis or psoriatic arthropathy who are etanercept. They are much more likely to get chest infections. So will patients on this drug. So I can imagine it's going to be used in a select cohort of patients, but it's not going to be something that will be used in every pericarditis. I think the majority of patients do tolerate colchicine pretty well. And colchicine is currently enjoying its moment in the sun, with a number of different studies that have shown the benefit of colchicine in other settings. And so I suspect we'll probably continue to use colchicine up front, first line, certainly for the near term.
Yeah. Well, I certainly do not have a lot of recurrent pericarditis in my practice. And, if I do encounter a patient, I work for, one of the largest regional hospitals for the Cleveland Clinic, but it's easy for me to send the patient to, my esteemed colleague, Dr. Klein, who was the first author on the study at Cleveland Clinic main campus, and, have him inject them with rilonacept. But great summary, important topic. There are certainly patients who have this condition. It's like you said, it's a very challenging condition to treat, and patients suffer a lot and go through a lot of hospitalizations and just uneasy, uncomfortable, recurring symptoms. And if you have a monoclonal antibody that can target the specific immunological agent that's responsible for the inflammation.
If I was suffering with pericarditis, recurrent pericarditis, and I was suffering in this way, and my physician said, look, we're going to put you on long-term prednisolone and have to take a steroid, then I would be pretty unhappy with that, because the long-term complications of taking those drugs is pretty high. But so something like this kind of biological medication would therefore seem a lot more attractive. But as you say, it's unlikely to be used by majority of our cardiology colleagues. It's going to be regional centres, subspecialty centres who are dealing with these kind of patients, because you've got to have the mechanism of follow-up blood testing and monitoring, and that's not going to be something that I think your average office cardiologist is going to be doing.
Okay, so what else do you have up your sleeve there, Sukh? What else do you want to talk about to wrap up 2020?
I think the key change, the sea change, is going to be these Sglt2 inhibitors. And I mentioned this at the earlier part of my conversation with you, and I think these drugs are incredibly exciting. I think so you know that story about an apple a day keeps a doctor away. You will have heard of that expression. And what I was amazed to read is that the SGLT2 class of drugs actually is derived from a chemical that comes from apple skin. And it just makes you wonder whether this whole thing about keeping doctors away may well have been keeping heart failure doctors away and keeping hospital internists away. But by having enough apples, you seem to reduce your heart failure admissions in so many of these drugs. And we've got data from last year. Obviously, DAPA-HF was absolutely humongous blockbuster release at ESC, and that led to real gasps in the room when those results came out that showed that patients without diabetes, with heart failure, had a big reduction in heart failure-related events, including a reduction in mortality. And then this year, there's empagliflozin, which comes as a very similar design study as DAPA-HF. Some subtle differences in terms of perhaps their heart failure patients were a little bit worse in terms of their level of severity. And what they show in around 7,000 patients or so is very similar outcomes. So you get a big reduction in heart failure-related events. Now, what's interesting about Emperor Reduce is they didn't hit a mortality reduction in this particular study, which is interesting because empagliflozin, obviously, in their type 2 diabetes studies, did show a mortality reduction in cardiovascular mortality, but dapigliflozin in declared TIMI, I can't remember which TIMI it was now, 52 perhaps, didn't show that mortality. So, you win some, you lose some. But I would essentially say that this basically confirms to us that these medications have a number of benefits, and we should seriously be considering them for our patients. And then there's this new medication that I'm less familiar with. We certainly haven't prescribed it, but we prescribe a lot of dapigliflozin and empagliflozin, is sotagliflozin, which was studied in the Soloist study. And what this has shown is that there's another medication in the same class that can reduce heart failure events. And this has some other, not quite sure what the long-term benefits of this will be. If there is a reduction of the SGLT1 inhibitor in the gut, and so therefore you reduce the amount of sugar that you absorb, that will, just like the SGLT2s cause increased urination and increased sweet urine and therefore infections, there is sotagliflozin seems to cause increased diarrhea. So there is perhaps a question over tolerability for patients. And there is some sad things. I think one of the companies that were developed this medication had some of their funding withdrawn, and so the studies ended up being stopped early, which is a shame because it looks like these set of medications probably are as effective as the other SGLT2s. But the take home that I've had from these studies is that in our patients with heart failure, they're going to end up on a number of medications. They're going to end up probably on Entresto. They're going to end up probably on a mineralocorticoid, and there's a new medication, finerenone, that seems to be highly effective, which may end up supplanting spironolactone or eplerenone. And then they're going to end up on SGLT2s. So in last 2 years, essentially, the treatment of heart failure has essentially been revolutionized. And I'm really, really looking forward to seeing further studies on this, because I think if you can get patients on all of these class of medications, we will finally be able to turn heart failure from something that we all recognize has got outcomes that are worse than many cancers to something that may well be a much more better condition to manage. And the other exciting thing that follows on from this is that the SGLT2s are being aggressively assessed in those patients with so-called diastolic heart failure, or heart failure with preserved ejection fraction. And I'm really hopeful, just like the FDA has recently altered its licensing for Entresto, that these drugs will show benefit, because then finally we'll have some evidence-based therapy for these really quite difficult to manage patients. I don't know if you have many patients with preserved ejection fraction and heart failure in your books, but we have a lot, and they're very, very difficult to manage. And we're usually stuck with just using diuretics. And there's only so much Lasix and spironolactone that you can give these patients. But, it'd be nice to be able to have therapies that have other big changes. And I'm hopeful that these studies, that when they come out, I think Emperor Preserved is coming out next year, 2021, or this year, as when this podcast is broadcast, will show some benefits. And then finally, we'll be able to make a big difference for these patients.
Yes, HFpEF is a vexing condition, and I run a valve clinic with my colleague, who's a structural heart interventionalist, and we see valve patients and aortic stenosis patients, and there is a good overlap of patients who also end up having a lot of diastolic dysfunction, because of hypertrophy and severe aortic stenosis. So I agree, and like you said, there is no treatment for heart failure with preserved ejection fraction. Certainly none that has shown to have any mortality.
I thought it was very
benefit.
interesting about the FDA's recent change in Entresto, because of course Paragon HF ostensibly is a negative study. It didn't show benefit in patients with preserved ejection fraction, although it came very close. And the p-value from memory was, I think it was 0.06, so literally just on the border. And a few statistical hoops that you could jump through, I'm sure you could suddenly make the study positive. It does raise questions, though. It does, if we're going to go back and start reassessing and evaluating studies based on subgroup analysis, then what's to stop us from doing that for all of our various drugs? And that it potentially sets a precedent that the FDA may regret going down the path of. But that's certainly, I found it interesting that they went down there. It's interesting. I suspect we won't get that here in the UK. I suspect NICE is, so for the listeners who aren't aware, in the UK we have a regulatory body or a recommendation body called NICE, National Institute of Clinical Excellence, which assesses medications and treatments, including device therapy, really aggressively. And it's always been this paragon of impartiality and lack of bias. More recently, I have to say that some of their decisions have been difficult to understand. And one of the complex things about it is that for example, if you're looking at something in the cardiovascular space, then the cardiologists and cardiac physicians will be involved in the decision making, but they won't necessarily be on the writing committee. And so sometimes the decisions seem a little bit unusual. And so that's it leads to some unusual decisions from NICE. But I suspect they will probably not give Entresto usage in those patients with preserved ejection fraction. But we're hoping, because we've got a lot of patients with it.
Yeah, well, Sukh, always great to have you on board, and thank you for the comprehensive summary for 2020. Great discussion. Detailed and practical tips and tools that our colleagues can use while taking care of patients in the trenches. I'll obviously see you around on social media, and hopefully once the meetings resume, which I'm hoping for, because I haven't seen colleagues in over a year now.
This has been something that we've really missed, is actually just catching up with people. And you realize now how used to we'd become just catching up. I remember we chatted in the faculty lounge of one of the conferences, and the social media is great in the fact that it breaks down so many barriers, and you can speak to people that you've perhaps never spoken to in person. And what's really nice about going to a meeting is that you catch up with all your friends from around the world. But none of us have had that this year. So I think there's going to be some, perhaps by summer 21, we'll have some people finally getting to catch up.
Yeah, no, ACC is on the cards, and I'm hoping that meeting is not cancelled.
Yes. Fingers crossed. I'll see you in Atlanta.
Yeah, no, that'll be terrific. It'll be terrific to see everyone and meet with everyone. Great. Well, Sukh, Merry Christmas, Happy New Year. I know we're recording this in 2020. This is going to be broadcast in 2021. So Happy New Year to everyone. We all hope that 2021 is a better year for all of us compared with 2020. And, we'll see you back in Parallax with our follow-up episodes.
Dear cardiologists, we want to make this podcast about you and for you. So please email us your critical thoughts, comments and questions at podcast@radcliffe-group.com and visit uscjournal.com for more information. You can also follow us on Twitter, LinkedIn, Facebook and Instagram at Radcliffe Cardiology for daily updates. Join thousands of cardiologists and become a Radcliffean by registering to radcliffecardiology.com. You will receive regular newsletters and gain access to hundreds of expert interviews, educational webinars, clinical cases, and peer-reviewed articles from our 6 medical review journals on general cardiology, interventional cardiology, arrhythmia and electrophysiology, cardiac failure, and vascular and endovascular surgery. Thank you.